Thank you very much. So, welcome to Where Next for GP CPCS, and introducing you all to the Community Pharmacist Consultation Service and to PCC's national offer to people in practices. So what are we doing today? We are hopefully providing you with a bit of an overview of the GP CPCS and to introduce PCC to you and to tell you a little bit about how we can support general practice. So why GP CPCS? At its heart, it is a digital referral from general practice, from reception staff generally, to a community pharmacist for patients. And that referral is, instead of booking a GP appointment for a minor illness assessment, you are referring your patients to your local pharmacist who will assess them for their minor illness treatment. The NHS Community Pharmacy Consultation Service is well established in community pharmacy across England and has been managing referrals in a different way to this, but managing referrals since October 2019. And it is worth saying that we've been using the NHS 111 service for both minor illnesses and urgent repeat medications. And we know from the learning from both of those pieces of work that GP CPCS provides a quick and convenient access to a primary care practitioner. Gillian says, is it only me who can't hear anything? Gillian, have you got the sound turned up on your machine? Just pop up thumbs up if other people can hear. I think other people are hearing fine. So what we are talking about today is the GP CPS service, and what the service is at its heart is the service provides a patient with advice and treatment for a range of minor illness conditions. It follows those treatments follow a consultation with a trained and experienced pharmacist. And I think it's worth just reminding people at this stage that all pharmacists, so everyone your patients get referred to, all pharmacists are qualified healthcare professionals who trained for 5 years to a master's level, and their training encompasses the clinical use of medicines, the assessment and management of minor illnesses, recognising red flag symptoms and providing health and wellbeing advice. So the kinds of people that you will refer to the GP CPS service are the kinds of people who the pharmacist is well used to and experienced in dealing with. So the aim of the GP CPS service is to relieve some of the pressure on general practice, and it is to make sure that patients can be navigated to the professionals in the primary care family who can help them in the most effective and efficient way. And research has, on the previous arrangements for the 111 and minor ailment services, research suggests that in the region of 6 to 8% of all consultations could be safely transferred to a community pharmacist. Now, thinking about your busy practices, what would 6 to 8% of your patients look like? Would that, for example, be maybe 8 to 16 patients? Could that be almost a GP clinic that could be referred? Thank you for the questions. Yeah, I will admit Tabitha from the waiting room. Thank you. There's an issue with, okay, we will touch on the issue with free prescriptions at a later moment. Fee, I think we've got a couple of people who keep bouncing back into the waiting room. So if they're colleagues of yours and are texting you, just let them know that we are doing our best to let them in. So the CPCS service If 6 to 8% of your patients who ring on any daily basis could go and see or go and talk to, have a telephone conversation with a community pharmacist and get their illness, their ailments resolved during that conversation, what would that mean for your practice? How many appointments might that free up? And I know I've said it before, but it is absolutely worth remembering that your local pharmacist is another trained and skilled health professional. So another aim of the GP CPS service is to really encourage patients to self-manage their own health more effectively and to really help GP practices who can digitally refer triage patients into the community pharmacist in a way that is convenient, safe and effective. And where it's working well, the evidence is suggesting that that is a successful engagement both for practices and patients. Patients are liking this service in those practices where this has been well established. So I am about to introduce you to Sibby Buckle. Sibby is an advanced pharmacist practitioner. She is a fellow of the Royal Pharmaceutical Society. She sits on the English Pharmacy Board and she is the community pharmacist in a busy city centre pharmacy in Derbyshire. And Sibby is going to tell us a little bit about what it's like being a community pharmacist and a little bit about what feedback she gets from patients and colleagues in general practice about the service. Thank you.
Thank you very much for that very kind introduction. I just hope I can live up to that. Yes, the consultation service, the community pharmacy consultation service is for some people still quite new. And one of the things that we are acknowledging both in GP practices and in pharmacy is that it is a culture change for all of us. And I think once we get the mechanics out of the way, and we know how to use the respective systems, your end and our end, it actually becomes a very good service and is a very good service and has huge potential. So that's what I would say, but I also acknowledge that there are barriers in place. There are barriers for you, there have been barriers for us. You know, there are obstacles to overcome, but they are achievable. And I think once we make it work, it will be really good because it does integrate us better into the MDT. We have, you know, for years coexisted and worked alongside each other. And yes, absolutely, we've had verbal referrals from surgeries. Thank you for that. And it's worked very well. But this is a more formalized referral. And the beauty of this is it completes the audit trail. So by making an electronic referral to the pharmacy, you are able to see that that patient has been referred. We do the consultation and then we communicate back to you electronically. So it completes the loop. And it's been a gap that's been missing for really since I started practicing as a pharmacist. And it's something we've long talked about and talked to the government about. So, you know, how do you know what advice we've given the patient? Well, this is going to achieve that. What I did, I thought it might be quite helpful for you if I just shared some of my top tips with you. We've been doing the NHS 111 service over the course of the last year. And then the GP service, referral service, we've been doing since really the beginning of this year, or I personally have been doing it since the beginning of this year with the practices around the pharmacy where I am. Now, obviously being in a city centre pharmacy, I use and have relationships with a lot of practices. And so the very first thing I'd say is, and it's my final point, but it's also my first point, is the relationship between the surgery and the pharmacy, knowing who your pharmacist is. And the surgeries that I have the most referrals from are surgeries where we have really built up what I would consider to be a really positive working relationship. There's a level of trust there. and they know that if they refer to me, that the patient will be seen. So the very first thing I want to talk to you about is making sure that the patient knows that this is a formalized referral. Over-the-counter consultations in minor illnesses are our bread and butter. We do that all the time. But we do it so much, and it's so much part of the way in which we work in pharmacy, that I personally don't do all the over-the-counter consultations. None of my pharmacist colleagues do. So we have pharmacy advisors, we have dispensers and pharm techs who are all trained NVQ1, NVQ2, NVQ3. And so when a patient presents at the counter, they will be seen by a pharmacy advisor or a healthcare assistant, and they're trained to ask the right questions. So it's only if the pharmacy advisor cannot deal with that query that they will refer that patient to the pharmacist if it is more complex. With these patients, obviously, if we telephone triage them, if we talk to them and we do a consultation on the phone, that's fine. We can talk to them directly. I will ask them to come in. But when they come to the pharmacy, I do make sure that they say, I have been referred by my GP practice in this consultation service. I need to see the pharmacist, so that my staff know that they are to come and get me for me to do a consultation with the patient in the consultation room. So this service is a pharmacist consultation, not a pharmacy advisor or a healthcare advisor. So that's another thing that you can reassure your patients with, that they are going to see a clinician, they are going to see someone like myself who is able to talk through with them. And we have done all the consultation skills training. Obviously we learn every day something new, but you know, it's what we do. So really, really important that you let the patient, make sure the patient knows that, which brings me on to patient dynamics, because we do have the same challenges with patients that you do. And so that you might tell the patient one thing and they come in and they tell us something completely different. Happens all the time. So that's where it's really important that we have a relationship between the surgery and the pharmacy. And that when I then ping back to you that I've completed the consultation, advice has been given, you know, we know that we've completed the loop. The third one I wanted to just flag to you is the phone number of the patient. I had a patient I tried to call 4 times, couldn't get through, phoned the surgery back, said, look, guys, I can't get through. They've checked on the notes and it was the wrong number. We all had the wrong number for the patient. It's a really simple, basic thing, but this is a telephone-based service in terms of our initial dialogue with the patient is over the phone. We need the right telephone number. Talking of telephone numbers, number 4 on my list is the surgery backdoor number. It's really helpful if we have that. Now, that will only be used for these pharmacist consultations where about 10% of them we're having to refer back to surgeries. That's what we're seeing at the moment. It is really important that we can get through to you. I mean, I run a care homes room where we look after about 50 nursing and care homes, and I hear my dispensers on the phone saying, you know, you're number 10 in the queue. I personally don't have time to, you know, none of us have time to do that. So having the backdoor number is really helpful, and we will respect that. It won't just be used inappropriately. And if it is, obviously, I would want to know that, and I would do something about it. Talking about integration and IT. Now, EMIS, if you're an EMIS surgery, EMIS is integrated. So whatever you put into your electronic database in the surgery, and I've got an example, I don't know if you can actually see that, but that is an example referral form where literally all you have to do is tick the condition that the patient has. You send that as a task to the pharmacy, and then we can see why that patient was referred. That then comes straight in from EMIS surgery. It comes straight into our pharm outcome system, which I bring up when I'm doing the consultation, and then when I complete that, it comes back to you. Unfortunately, at the moment, system 1 is still via NHS mail. So we have to proactively go into our NHS mail and download your referrals. Ironically, we then print them off because I have 3 floors in my pharmacy. It's a very large one. So we have to print those off, and then I have to populate pharm outcomes whilst I'm doing the consultation with the patient. So it's clunky. And there has been resistance from some pharmacists with the system 1 surgeries because of the fact that we have to use NHS mail. So I acknowledge straight up front that has been a barrier. But we are working with the IT provider, and it looks like we have made some progress, and it looks like Pharm Refer is going to be agreed and integrated into system 1, which is going to make a big difference. And it means that both systems will be integrated with the pharmacy system, and hopefully we'll have a system a bit like COVID, where as soon as we had vaccinated someone with the COVID vaccination, that was put on their record, sent back to you, and we all shared that data, so we all knew and we didn't over-vaccinate our patients. Timing of the referral is my number 6. So we look at the referrals in the morning. By some pharmacies say by 10 o'clock, some say by 11, to then do a same day consultation, get the patient in, and then we look again at 4 o'clock. But if some of the referrals come through after 4, that is actually where I would say speak to your local pharmacy, because if somebody comes through to me at, say, 5:30 and my pharmacy closes at 6, they won't be getting a same-day consultation. We will have to see them the next day. That's just common sense. So just clarify with your pharmacist colleagues what time their last same-day consultation will be, because obviously we're saying to patients this is a same-day consult. And then it brings me back to my point number 7, which is talk to each other. As I say, I think it's exciting that we're now formally being included in the team, in the multidisciplinary team, the surgery team. I think COVID has changed, and it's good that COVID has changed a lot of the ways in which we work. Our ways of working have changed. And so as we've all got used to, and just as we're doing today, having a Zoom meeting, so doing an electronic referral like this, I think is now something that we will feel comfortable with. And as I say, once we overcome the mechanics of it, I think we will utilize it more. You will be given some targets, I think, in terms of what we're looking to achieve. I know that in our area, we're looking at 35 referrals per 1,000 patients in the practice, which works out, and I think in a 10,000 practice works out at about 7 referrals a week. So it's about 1 a day if you were going to do it every day. So it's not onerous, and it's not onerous for the pharmacy and the pharmacist yet. But obviously, if this takes off, we might have a different dialogue. But right now, we're all trying to familiarize ourselves with it. There is a lovely chart that will be shared with you after the this seminar webinar, and that I suggest you keep. And I've certainly said to my pharmacists, keep that next to your computer, because that highlights what those minor ailments are that you can refer. Because when you're in a busy GP practice, and my daughter's just a GP, and you know, we've had big discussions about this, and she says, "Mom, you know, when the UK navigators or receptionists are triaging someone, where do you send that patient? You need to make your decisions very quickly. Have that chart next to you, and you can glance at the chart. You can see, oh, it's a bee sting. The pharmacist can do that consultation." So that's probably enough for me to say right now. I'm aware I've had my allocated 10 minutes, but very happy to deal with questions in the chat. And just to say again, you know, it is a culture change. Pharmacists are getting used to this system. I think we're doing this together, and it's great that somebody like PCC is coming along to help facilitate this. I think, you know, we're very good in our respective professions at embracing change, and I think once we get this up and running, I have high hopes that it will be good. The feedback we've had from patients so far has been very positive. They've liked the fact that they have been able to get, certainly when we do it a same day consultation, they like the fact that they are taken into the consultation room. Bear in mind, every pharmacy now has a consultation room, so it is a private consultation. It is a consultation with the pharmacist. But please make sure your patients know to say that when they come to the pharmacy. Thank you.
Thank you, Sibby. And what I'll do is I will carry on, and maybe Sibby, there are a few questions. I don't know whether you're able to pick up a couple of them. I think to say that we can't in this webinar address any technical issues about EMIS or System 1. But there will be somebody in your local patch who can.
And her name is Lindsay Edwards, And Lindsay is a senior receptionist at Willowbank and Adderley Green practice in Stoke-on-Trent, and she has been involved in implementing CPCS. And she's recently taken on a role of supporting CPCS implementation in other practices in North Staffordshire as well. So I'd really like to welcome Lindsay, and she's going to share her experience with us this morning. So Lindsay, over to you.
Morning. Okay, so we use CPCS on a daily basis. We find it very quick, the patients are happy with it. The staff are confident in to refer because they realise that they can release appointments for the GPs for more serious illnesses that we get through later on in the day. The pharmacists, we've spoke with them, so they're aware of the referrals coming through. So within 2 to 4 hours, the pharmacists have contacted the patients. If they haven't contacted the patients, then what we tend to do to stop the patients calling back the surgery is to give them the pharmacy's number, so that the patient can contact the pharmacy directly, rather than ringing the surgery back and sitting in the queue and getting frustrated that nobody's contacted him. So it is very handy. It's very quick to do. The patients seem to like it. You'll get the odd one that doesn't want to go to the pharmacy, but we just ask the patient just to try it, and then you tend to find that they will go back to the pharmacy after, rather than ringing the surgery and demanding an appointment.
So thanks, Lindsay. So could you tell us about how you introduced the CPCS into your practice, how you got your reception team on board, and what you needed to do really to get going?
Okay, so we just showed them the training, which is very straightforward. It's on the EMIS, so your EMIS you're using every day. It takes the same amount of time as it would to make an appointment with a GP or an AMP. So it's quick. You're not on the phone longer than you should be. The girls have got all of the information, what you can refer and what you can't refer to the pharmacy. So that's next to every computer, because you do get new members of staff coming into GP that aren't qualified, never done the job before, so they're not confident enough to refer. So we always make sure we've got a sheet there for the CPCS, what you can and can't refer to the pharmacies for.
And how do you support the team? Do you review how it's going with everybody, particularly when you got started?
Yeah, because what you can do on the CPCS, you can actually go on report and you can see what members of staff have been referring. So if you've got one member of staff that's currently referring all the time, then you just review it weekly and just props up the girls and say, come on girls, look, she's done more, come on, you get referring as well. We've had people ring in, we've heard the conversations, so you just keep a track of it that way. So sometimes it can lead into a competition because one person's made more referrals than you, so it is good to have the reporting on the CPCS to keep an eye on who's referring to the pharmacies.
And do you have any contact with the community pharmacists, or did you do that before you got started?
With every GP surgery, you do get the odd pharmacist that you have a little bit of trouble with. But generally, with our practice now, we've put things in place. So we've got good communication with the pharmacists. Sometimes the pharmacist will blame the surgery for the patient not getting a prescription. So we ring the pharmacies now, speak to them directly so they know it is by name. So it's just putting things in place to get a good communication with the pharmacies. The ones around where we are all pretty good.
And what sort of proportion of bounce backs do you get, Lindsay?
In this month, we've had two bounce backs we've had this month, but that was from a new member of staff. So as soon as we get them back, we just show her what's gone wrong, and you put it straight. You know, you make sure that that they are looking at the sheet for go off. But we've had 2 in a month, so that isn't that bad at all.
No, that sounds good. And what about red flags where they have to refer back into the GP practice? Do you get many of those, and how does that work? Does the pharmacist phone you?
Yeah, we don't get that many. We get probably 3 or 4. But generally we'll probably get an email from the pharmacy, so we're on emails every day. If the pharmacists haven't got time, they know that we're picking the emails up, so as soon as we get that email back, then we'll contact the patient directly. And
do you save any slots in your appointments for red flags coming back? Is that how you do it?
What we do in our surgery is we have a query book. So if patients can't be seen that day by somebody, we'll put down what the problem is, and the doctor will speak with the patient, or the doctor will give us advice what to do if they've prescribed them something, or if they need to go to A&E, and the doctor will deal with it that way. So we don't save appointments, we have a query book so that we can directly go to the GP, speak with them. If they haven't got time to ring the patient, then we'll call them and advise them what the doctor's advised us to tell them.
That's great, thanks. Can you tell us, have you had any feedback from patients at all about the service?
We haven't, no feedback at all from patients. I mean, that's probably something what we could tend to do, because if obviously on the reporting you can see who's been referred, so we could do that, go back. That would be a good idea for bringing, actually, yeah, just to see what they feel like.
And what are your top tips for either for getting started and also for maybe explaining it to patients, to getting them on board with it?
Yeah. The top tips are the patients will get dealt with that day. If they need antibiotics, they'll be able to get them referred for certain elements from the pharmacist. They won't be left. Getting the patients on board, it is easy. You do get the odd one that doesn't want to pay for the prescription if it's something that they're advising to buy over the counter. But yeah, we basically just let the patients know that they can get dealt with that day. You can't be left, and they don't have to leave their house. They don't have to ring anybody else. The pharmacist rings them directly, and they're going to get a consultation with a qualified healthcare.
So it is that sort of that warm referral, explaining that it is a local healthcare professional and that it's a direct referral for a consultation rather than just signposting.
Yeah, it says. I mean, you don't get that many people that will query it. Like I say, you get the odd person that will query it, because obviously sometimes you'll say they can advise you what to buy over the counter. Some patients don't pay for the prescription, so by saying that to them puts them off. But generally, that's the option that they've got. You tend not to try and give them the option of an appointment. You try and tend to put on, we can refer you to the pharmacist. The pharmacist will do a consultation, and you get seen by a healthcare professional. Because the majority of things that you can buy over the counter now really shouldn't be getting prescribed in the surgery. So that's how we put it to our patients.
Somebody's asked in the chat, Lindsay, the report that you mentioned about how you can see, how many patients have been referred and who they are. Where do you get that report from?
So when you click on to do the referral, at the top you've got create a referral. Right at the far end it says report, and it gives you all the information on that side.
So that's on the EMIS system that you're working on, isn't it?
Yeah, it goes to create a referral, yeah.
So it might be different for those practices that are on system 1. They might have, it might look different on their system.
Yeah, it might do, yeah.
Okay, I'm just going to have a look in the chat to see if there are any other questions for you, Lindsay. I mean, from what difference do you think it's made in your practice having this service?
It's made a lot of difference. It's released appointments for GPs. We're not having patients ringing up and expecting everything on prescription. So obviously the cost will come down on what is getting prescribed, because the patients are buying it from over the counter. It has made a lot of difference.
Do you know, somebody's asked in the chat whether patients who've opted out of sharing their data are not able to be referred. Do you know anything about that?
I haven't come across one yet. So
Okay.
We haven't had that many patients to opt out, if I'm being honest.
Okay. So that might be something that we need to check and put in our FAQs.
Yeah, definitely.
So, anything else, Lindsay, that you'd like to share with people from your experience?
I just hope that the surgeries get on board, because they'll realise how effective it is for the patients and for the GPs and for the AMPs, how it will release their appointments for somebody coming in, you know, whereby they can get antibiotics from the pharmacy, UTIs, coughs, colds, sore throat, sickness bugs that they've had for under 24 hours. You know, there's a lot of things that you can actually go to the pharmacy for that will release the appointments for the GPs for more people with serious ailments that need to come in and be seen.
That's brilliant. Thank you so much, Lindsay. I'm just having a look in the chat to see if there are any more questions for you. Just to reassure people, you do not need to be on EMIS to do this system. It's equally available on System 1, and there are templates that you can use. Everybody is using systems in a slightly different way across the country, so it depends whether there are some you use a system with NHS Mail, or you might use an integrated system on either EMIS or System 1. Your local support from your CCG or your LPC will be able to advise you on how to use it if you haven't already received that information. But I think most practices will now have received information about how to do it, depending on whether you're on System 1 or EMIS. We have videos on our resource hub, which I'm going to tell you about shortly, which apply to all different permutations. So whether you're System 1 or EMIS, whether you're on NHS Mail, or whether you're on the integrated system, we have a video to talk you through that process on our website. So I will tell you about that in a moment. I'm just checking again to see if there are any other questions for Lindsay. So somebody's asking if they can have a copy of the criteria of what we can refer that you currently use. I'm going to show you that in a moment. So the criteria is available on a GP CPCS referral toolkit that was published by NHS England. I think, Lindsay, that was the toolkit that you used to put it in place.
Yeah, that's the one I use. Yeah.
So we will make sure that you all have access to that after today's session, and I'll just show you what that looks like in a moment. Just looking for a few more questions to see if there's anything else for Lindsay here. So yeah, I think there are there are some questions about things like UTIs and antibiotics, and I think you mentioned antibiotics, Lindsay.
Yeah.
But pharmacists have different capabilities and protocols in place. So not every pharmacist might be able to deal with the antibiotics or the UTIs. That would be outside of CPCS. CPCS is really focused on those minor ailments that Lindsay was describing and that are on the list that I was showing you, and it's really focused on things where the pharmacist can offer advice or can offer advice and an over-the-counter medicine. So that's the area of focus for CPCS. So thank you so much, Lindsay, for coming and joining us today and sharing your experience. I hope people have found that helpful to hear from reception team leader, because I think it does need leadership, doesn't it, within the team. You do need to get your team on board and help them to understand what it's all about, don't you?
Yeah, you do.
And give them that support to keep going and give it a try. So thank you very much for your time today, Lindsay.
No problem. Thank you. Take care.
Thank you.
Build on what Sibby was saying. These are some of the kind of minor ailments that can be referred through the scheme. And while it's not an exhaustive list, it gives you a flavour. And I think my next slide is a little snapshot of the list that Sibby was showing you. Something maybe to think about is to just think about how are you doing your general care navigation. So, for example, these days, a lot of practices have got a phone message. So if somebody rings up, they don't get straight through to a reception team member. They get a phone message saying our reception team will be asking you what brought you here today, or words to that effect, in order to signpost you to the best person to help you today. Now, one of the things you might want to consider is adding some ideas about who that person may be to that phone message, because we are getting familiar in general practice with staff at reception level signposting people to advanced practitioner nurses, to first contact physios, to first contact paramedics. And actually this pharmacist role sits entirely within that kind of general care navigation and signposting offer. So the document that Sibby was talking about, it looks a bit like this, and it's really useful because it talks about what conditions are suitable to be referred and what conditions you mustn't refer. And once we've completed the webinars on Thursday, we will be sending you out a copy of this with the slides in a little bit of a tidier condition so that you can read it. One of the things that we talked about a little bit about on our previous webinar was whether patients got a face-to-face or telephone consultation. And NHS England have really helpfully sent us this snapshot of London data that shows that around 75% of consultations are carried out by phone in London. And we know that that's a similar pattern across the rest of the country. So that is helpful to think about, both in terms of how your patients actually physically get to a pharmacy, particularly those of you who are in rural areas maybe. And it also gives, I think, some reassurance that 75% of those consultations are closed off in that phone consultation, and that patient leaves with the appropriate advice and an outcome that they are satisfied with. So that is worth thinking about, and that's worth just understanding. Just some top tips to build on Sibby's top tips. What we would suggest and what we know works is build some relationships with your local pharmacy. We've had some comments in chat. I think we've had one, if I can find it. I think Francesca said, we went to our local pharmacies and personally spoke with each pharmacist. And we work with those who've agreed to the service. That has saved that practice a lot of hassle. And they also agreed a cap for referrals, as one of the pharmacies was worried about capacity, and that has worked out really well. So this is about thinking about how you make a partnership with your local pharmacist and your local pharmacies. It is also about giving your staff the confidence that this is worthwhile to signpost that 6 to 8% of patients to. So this isn't for every single patient. In the same way, if you've got advanced nurse practitioners or clinical pharmacists on your team in the practice, or you've got MSK practitioners, or you've got a mental health practitioner. Not all patients are suitable for a signposting away from a GP referral, but with 6 to 8 patients every clinic every morning being suitable to be seen by a pharmacist, that means that you could, for some practices, be saving a whole GP clinic. And that is where I think it's worth starting to think about, that actually it's the saving of those GP appointments in order for the people who need them most to get to them. And I think just let's remember that we need our staff to remember that this is a signposting to a knowledgeable, experienced clinical professional. And it's about how you work with your frontline staff to give them the confidence to carry on with this. And I think it's also worth saying things are always difficult when we start. So one of the things I'm going to tell you about in a moment is the PCC support that can help you really make the best start with this, or if you started, to think about how you can explore it further. But I just wanted to, I was talking to a colleague from our facilitation team, and she's a practice manager who has implemented GP CPS. So I asked her what she would kind of say about it. And what she said was that actually her practice is a large central London, incredibly busy practice, and they got involved in CPCS very pragmatically. They couldn't find enough appointments for patients this winter. So what they found was that actually signposting patients to the local pharmacist really helped those patients who needed some support for minor ailments to get a next day service or a same day service. And what she said was that it was another offer. Staff, her reception staff and care navigators welcomed this because it was something else they could offer to patients that could happen while they were on the same day. What she also said was that it does take a little bit of time to make sure that all of your reception staff are kind and confident and can explain this to patients. So what she said was her learning was it's no good if only 1 or 2 people know about it. What you need to do is the whole reception team needs to know about it. The whole reception team needs to feel confident and comfortable about how they can be kind and compassionate and make that suggestion to a patient about moving through to seeing a community pharmacist. And lastly, she said, just remember, this is something new. And when we're learning something new, it takes more time than things that you are familiar with. And she said, let's remember that actually staff have got a lot of things to remember. So check in with them. Check in with them often, sit in reception, think about how they feel when they're trying to sort of get their words across to a patient. Maybe think about what your practice wants to say, maybe think about what your practice wants to frame this as. But remember that it is at its heart, it's about giving patients another choice. There is another choice for patients as well as the services the practice already has on offer. Sibby, do you want to come in and pick up any questions quickly before I move on to what PCC can do to help people? I can see that you've put some comments in chat.
Thank you. I was furiously trying to answer. I can't just see who asked that question. Was it something about there's an issue with patients who receive free prescriptions not wanting to use the services they then need to pay. Now that is I was just going to acknowledge that. That is absolutely valid and an absolutely valid concern. But I was on a previous webinar and this was raised with paracetamol, and Sarah Jarvis, who was on that one, the GP on that one, said, well, actually, you know, if it's paracetamol, we're not meant to be prescribing that anyway. We in our practice, we have our protocol is that patients have to buy their own paracetamol. So bear in mind that when they come to the consultation, I am not doing that consultation with a view to selling that patient a medicine. I am doing that consultation with a view to finding a solution for the patient, the most appropriate solution for that patient. And I have 5 options. My first option is to give advice, and that would be advice only. The second option then is to recommend an over-the-counter medicine. And actually you can buy paracetamol, I think, for about 50 pence. I mean, it's not, for most people, it is not an obstacle. I can then give advice and refer on to another NHS service. So, for example, some pharmacies offer extended care PGDs or minor ailments PGDs, where we can actually supply some of the medicines for minor ailments under a protocol that we have with the local CCG. So again, it's worth checking what agreements are in place and what local services are provided, because you might find that actually sometimes under that agreement, under that protocol, medication can be supplied free of charge. It hit Facebook, I think, when somebody put on that you could get Calpol free of charge in Nottingham, and the shelves were clear within a day as all the mums came. It went on to Mumsnet, and all the mums came in to get their free Calpol, but it was quickly knocked on the head by the CCG. So, you know, they and actually, you know, we had to actually refuse some of the mums, because you know, you're not meant to, the services aren't there as a just in case, they're there to actually treat. So it's not a free for all. The fourth thing I can do is signpost. And so, for example, if someone's got lower back pain and I actually think they need to see a physiotherapist rather than the GP, then I would signpost them to a physiotherapist. And then, of course, we refer back if we need to the practice. Having said that, we will also, so for example, if someone came in with a UTI and I thought they had sepsis, you know, I would be referring them to A&E. If it was something that the weekend and they needed antibiotics for an insect bite that I couldn't deal with over-the-counter meds, I'd be referring them to the walk-in centres. So we will carry on doing what we already do, but the beauty of this system is it gets captured on the system and that gets fed back to you, so you know if it was only advice given or if it was only advice plus a sale. One of the things pharmacists aren't very good at is capturing what it is we have exactly done. I think you're a lot better in medicine than we are. And so, you know, I might say advice and OTC sale when I've written that into the message to send back to you. Or I think it's coded as well. But you might not necessarily know what the product was. That's something that we'll have to look at in terms of how we feed that info back for you. But that's a national problem with the service, I think. But suffice to say, for simple, straightforward, over-the-counter medicines, most people, when they know they can get a solution that day, are reasonably happy to buy something if they need to.
Thank you, Sibby. That was really helpful, and I think that's picked up a number of the questions in chat. So I just want to tell you a little bit about what PCC can do to offer the support we can offer. So we have something called the CPCS help desk, and you can email that, and within 1 or 2 working days, one of us will have got back to you with an answer to your question. We have got a hub that you can join that is run through NHS Networks. So if you're already a member of NHS Networks, joining is easy. If you aren't a member of NHS Networks, then becoming a member is very easy. And you can access a range of collated resources, but you can also have a discussion with colleagues, ask questions, a bit like people are doing in the chat today. People are asking questions, other people are providing some ideas for solutions and answers and things that have worked with them. So it's a space for you to check out and check in with other people. And we are offering some free, so it's fully funded, there's no cost to practices, training for reception and care navigation teams in things like leading change and influencing skills. And we are collecting and sharing all the useful tips, particularly some of the ones that are coming out of these webinars. And we're sharing case studies about what works so that you can shortcut what you do in your practice in your PCN by learning about what other people have done and by learning about what works from other people. We're then also working with regional leads in CCGs and ICSs to identify practices where some one-to-one support will help you to really get going with this. And what that one-to-one support looks like is one of my colleagues would give you an email or a ring and say, can we help you? Can PCC and you work together? And that kind of tailored support will really give you time to look at what's getting in the way of you making more referrals or getting this implemented. And we will then help you think about what your action plan can be to remove some of those blockages. And that facilitated conversation will be particular to your practice or your PCN and confidential to your practice and PCN, and will be about you having some time out with an experienced facilitator who works in very much a kind of coaching way to see what your practice can do to help you kind of really get on board with this. So how can you get involved? You can get involved by contacting your CCG ICS lead for CPCS and let them know you're interested. And on our website, there's a whole list of links to the regional teams. You can join NHS networks and you can sign up to the CPCS hub. And if you know you're doing it brilliantly, or you know that you've got some learning you want to share, or you've got some feedback from patients that are positive that you want to share, or you want to share how you've made a relationship with your local community pharmacists and pharmacies and how positive that is, then get in touch with us via the help desk, and one of us will be in touch to help write up a case study. And those case studies will be shared widely. We'll share them with NHS England. We will share them on our website, because we want to make sure that we recognise what works and recognise that what works is different for each practice and each PCN. So I'm going to just check in, excuse me, while I just look at the questions. Sibby, was there anything else you wanted to pick up on? I can see again, you're being brilliant in chat, and we will make sure that when we send you the slides, we send you a summary of these questions and answers so that you get to keep those.
I know before there have been questions about the funding, and there is funding available, I believe, through the IIF for practices. So there is reimbursement, because in fact, it was my daughter hit me with this one. She's saying, well, Mum, you know what, why should we refer to the pharmacy? What's in it for us? I said, that's very commercial. But you do get funding through the IIF. I don't know the formula myself, but there is a reimbursement of your time. And then as far as the pharmacy is concerned, the pharmacist gets paid £14, I think it is, for a consultation, but that comes out of the global sum, so it's not extra money for pharmacists. So actually pharmacists need to do it. It's a nationally, I think somebody asked there, could every pharmacy do it? Can every pharmacist provide this type of consultation? And the answer is yes, it is a nationally commissioned service. So any services that are nationally commissioned, every pharmacy can do. And actually, we don't need specialist training to do it. You know, we have to do our CPD cycles every year and be revalidated every year. So pharmacists are regulated by the GPHC, so we have to do that anyway. But there is also an organisation called CPPE, which provides training. And you just self-certify that you've completed that training if you're a pharmacist. And then also the Royal Pharmaceutical Society, in conjunction with the Royal College of General Practitioners, has pulled together a program of training webinars. It's 2 sessions, and it goes through various of the case study scenarios that you might encounter. And it's really worthwhile for a pharmacist to do that if they haven't done it. So you can always recommend that to your local pharmacist if they're saying, oh, I'm not very, because they might not be confident. And that helps with their confidence in terms of providing a service like this. I hope that's helpful.
That's great. And we've clearly got some people who are sitting in on today's webinar who have got some positive experience. So I think Lindsay has suggested that the benefits for GP practices is freed up appointments and happy patients, and I would absolutely agree. And Francesca is saying that they started only last month and they've done 51 referrals already, and patients seem happy to have another option, and they think it's a great scheme. So, and we've got a reminder that the local pharmacy committee can also support this service within both practices and community pharmacists. So I think our advice at PCC is it's worth giving it a go. I think where people are getting it bedded in and getting the change in the practice to happen, it's having positive benefits both for the practice and for patients. And I think that is positive. We've got a couple more moments. If people have got anything they want else to ask in chat, we can try and pick them up. What I'd like to ask you to do now is we've got a little smart survey that Fee, I think, is going to load into the chat. Let us know what it is that you liked about today. Let us know what you would like to know some more about. And PCC are very committed to making sure that this programme is as responsive to practice and PCN need as possible. So just all you need to do is click on the link and it will take you through on your browser. And I think, and if you can just complete that, that would be great. And we'll keep an eye on chat if there are any other questions coming up. Francesca is saying that they got word out to their patients that we were making referrals to have an appointment with the pharmacist. And that seems to be a positive way forward.
I think what Francesca is saying is we word it to our patients that we are making a referral to have an appointment.
Yes.
So I think what they do there is they actually, I think it's the point I was saying about making the patient really understand that this is an appointment, so that when they come into the pharmacy, they say, I've been sent here by my surgery to have an appointment with the pharmacist. If it's a telephone consult and I've already spoken to them on the phone, but I feel the need for them to come into the pharmacy, I will actually say to them as well, please, when you get to the healthcare counter, please make my advisors aware that it is a consultation with the pharmacist. So it's just, we've had some feedback from some surgeries that and it was early in the service, but people got to the pharmacy and then they saw a pharmacy advisor. And they said, oh, I'm here with whatever their condition was, but didn't say I'm here as part of the referral from the surgery. So we just don't want, that's what I mean about the patient dynamic. We need to help our patients to help themselves as well.
And I think it's also that framing when your reception and care navigation staff, it's helpful to tell people that it is a dedicated appointment for them and that the pharmacist is expecting them and that it is an appointment with the pharmacist, so that, and just to remind people that it will be, if it's a face-to-face consultation, it will take place in a private room exactly in the same way as it would have been if you're speaking to any of the other healthcare professionals at the practice. So it is that kind of idea that this is a private consultation. So thank you to those people who are already doing it. That's great. We can't today give you the details of how to do a referral in System 1, simply because there just isn't time in the time we've allotted. But if you want to drop a line to the CPCS help desk, we can refer you on to the leads for your area who will help you understand that. Or you can drop your own email to your CPCS lead. There's a list of those emails on the PCC website. And Jeanette is helpfully reminding us that the IIF is 0.65 referrals per 1,000 patients. That is the kind of DES standard. I understand there may be some local variations on that, but that's a good kind of rule of thumb to get you thinking about what that means in terms of how many patients and how that flows. Thank you for that. And that's great that we've got some links to the Outcomes for Health website that is part of the training package that many places are using, that really starts getting you going. When you get the slides back, there are also a couple of films in there that you can show staff, and you can share with maybe your patient group about what GP CPCS is all about. Neither of them are very long, so it's not a big ask to think that you might show that to staff in practice in a meeting or something like that. Okay, thank you very much for all of that chat activity. Really kind of lovely to see so many people engaged. Hopefully some of you have completed your SMART survey or have kept the browser open to complete it when the call is finished. You will get another chance to complete that when we send out the slide. There will be a link to this. And lastly, I'm just going to ask you, we've got a really quick poll just to get a sense of where today has landed with you. So I think Fee is going to put a poll up on the screen. It's just one answer. Have a little look and see what that feels like. I'll just give people a moment to do that. And all you need to do is just press the answer choice that you like, and it will pick it up. And just to remind you all that please do contact the help desk if you would like to be involved. Please sign up to NHS Networks. And if you are one of the people who have been providing some really positive feedback in chat about how well it's going in your practice, and you would like us to write up what you've done and what you're doing as a case study, then we would really welcome the opportunity to talk to you about that. So get in touch with us via the help desk. Unless there are any more questions or comments from people, which I think we've picked up most of them, I would like to say thank you all for joining us. I'm looking forward to meeting some of you as we start our conversations with practices, and I'm looking forward to hearing some of the good work that you are doing. Sibby, thank you very much for your time and your experience and sharing what it feels like from a practitioner pharmacist's point of view, and good luck. I look forward to working with you all in the future. Take care. Fee, if we can stop recording, that would be great.